Well, hello, everybody. My name is Peter Werwine. I'm Senior Editor at Managed Healthcare Executive. And today I'm talking to Dr. Karen Lu. She's PI, the Principal Investigator of the Magenta Trial and Chair of the Gynecological Oncology and Reproductive Medicine Department at MD Anderson. And we're going to be discussing Abstract 1506, which is results from the Magenta Trial. So thank you for making time today.
It's my pleasure.
It might be good to discuss what you're looking at here, because the Magenta stands for Making Genetic Tests Accessible. So why are we looking at this issue at all?
So ovarian cancer is a deadly disease. And we know that in the general population, most women have about a 1.5% likelihood of getting ovarian cancer. So it's not a particularly common cancer. We also know that there are some women who have up to a 20 to 40% lifetime risk for ovarian cancer. So there's a huge difference between a 1% risk and a 40% risk. And so we know that if we can identify these women, then they can prevent that disease from happening. So genetic testing has been around for several decades, but we know that very few women take advantage of this very powerful information. So Magenta is a study that's looking at how we can make genetic testing more accessible and seeing if an electronic delivery is safe.
So implied in that is that there's problems with accessibility. So how do people access the testing now? And I guess it's interesting that you're doing a virtual delivery system, because that's what we're all talking about these days because of COVID-19. But I just want to discuss for a few minutes the inaccessibility, which is implied in the name of the trial.
Yes. So traditionally, genetic testing is delivered by going to have an appointment with a genetic counselor and often a physician who works in collaboration with a genetic counselor. That's an in-person visit. And then they may decide to think about it. Then they'll need to go back to have their blood drawn. So that's a second visit. And then they'll need to go back for a third time to get their results and for that post-test genetic counseling. Now, there have been some studies that have been done in the last few years that have shown that phone counseling can actually increase the accessibility. But we wanted to kind of go one step further and say, can an electronic delivery of information take the place of either in-person or phone genetic counseling for both the pre-test part or the post-test part. In addition, we know that rather than getting your blood drawn, for the majority of people, they can actually use a spit kit. And so the whole process can be really delivered at home.
I believe this is a four-arm trial. So you had two cohorts here, a family history cohort of roughly 3,000, and then a cascade cohort of 711. The family history, I kind of understand. The cascade, I couldn't get my head around. So could you just discuss those two cohorts, please?
Sure. The family history cohort is women who have family members that have either ovarian or breast cancer. So that's fairly straightforward.
Right.
The other cohort was meant to address individuals who have someone in their family who has tested positive for a mutation. So they may live in Seattle, but the rest of their family is spread throughout the US. And so in that circumstance, it's really important to notify those relatives that there is a mutation in the family and then allow those individuals to access genetic testing. And so that cohort was made up of individuals who knew that they had a mutation in their family.
And are we, so it's in both cases, It's an individual who has some information, some signal that they might be at risk. And that signal in both cases, although one is sort of by inference or by implication, is family history. The other is a signal of an actual positive test of a relationship. But in both instances, we're looking at people who might fall into that high risk group. Now let's talk about the four arms of the study. And maybe you could just sketch them for me and
Sure.
for the listeners and viewers.
Sure. So one arm I would consider the control arm. And so in that arm, individuals had to have pre-test genetic counseling by phone. And then they also had to get post-test genetic counseling by phone, whether their result was positive or negative. And that's what we consider now standard of care. So phone counseling is considered equivalent to in-person counseling. So then the second arm was looking at, we wanted to ask, what about if we still require them to have pre-test counseling, but not post-test counseling. So let's say they tested negative, they could get their results online with some information, and that would be sufficient. And then our third group was individuals who didn't have to have that phone call before the test, could just get the information online, do their spit kit, and then but we required them to have post-test counseling to kind of, even if their result was negative, to hear about that. And then our last group had neither pre-test phone counseling or post-test phone counseling unless they were positive. So kind of the safety net across the entire study was that if you tested positive, and about 6% of our patients tested positive, so the vast majority did not test positive, then they would be required to have a phone conversation with a genetic counselor.
So it seems like the variable here, the thing that's changing is phone counseling and whether we really need to deliver it or not to affect the outcome that you chose to measure in this particular case, which is cancer distress.
Correct.
And I believe the result was non-inferiority, which would suggest in sort of plain English that we don't necessarily need phone counseling here. Is that what you would say?
So we were surprised by the findings. You know, we are committed to this field. We partner with genetic counselors. We really understand the value of that additional information that is delivered. And so it is a balance between delivering to each patient sufficient understanding of what this testing means and what it doesn't mean, and making this very powerful medical information available to a much broader group of individuals. So I think that we were surprised that that on a broad scale, there really wasn't a difference, that those individuals who went through the process and watched a video to explain the benefits and limitations of the testing and received information on the back end about it really were fine with that method, and that there wasn't increased distress. Now, that was our primary endpoint. We have secondary endpoints as well that we looked at, you know, regret, anxiety, things like that. And there was no difference in those either. So, you know, it may not, the study design may not have teased out very subtle differences,
Right.
but I would say as a whole, it really showed that this type of testing, which is available commercially now, can be used.
What do you think this says about the role of genetic counseling in this area of genetic?
So I would say that there are two things that are true about genetic counselors. One is that they provide just a wonderful service to patients in terms of explaining fairly complicated information. And two, we don't have enough genetic counselors in this country. If we were going to stay with a model of kind of that traditional model of pre-test and post-test counseling. So I think, like all of us in the post-COVID era, is that we're going to have to think a little bit differently about how we deliver information. And with a lot of the therapeutics that have come out that are relevant to, say, BRCA positive individuals or Lynch syndrome positive individuals, there really is a huge need now for more for incorporating germline genetics into both the practice of oncology and then also in terms of the treatment of the general population to identify individuals before they get cancer. So, I would hate for anyone to say we don't need genetic counselors. They're not necessary. I think what we need to do is to use them and use that limited resource in the most effective way possible.
Just a couple more questions. So what would be that way that you've just suggested?
So one way is to really focus on those individuals who test positive, right, and also individuals who have a really striking family history but who test negative. So that would be kind of one of the ways that that I think makes sense. And then as we move towards moving genetic testing more out to a general population that has strong family histories, it may be that we don't need to have genetic counselors on the front end have an intensive conversation before they undergo their genetic testing.
Although there were some people in this study in some arms that did not get counseling, they were given a little video explaining the test and what the results might mean. So there's some delivery of information. They aren't just taking a test and that's it, right?
They have to have that delivery of information. I think that's a crucial part of any medical test, is that you understand what it is, what information you'll get out of it, and some of the limitations.
So does this result make you more comfortable with the commercial tests that you or I could just order and take online? I think there's been some reservation about sort of putting these tests out there in the public, that people would misunderstand them. It would cause a lot of worry and so on. Does it make you more comfortable with those products and services that people can buy?
So I think it's really important to distinguish between what I call hobby genetic testing and medical grade genetic testing. So hobby grade genetic testing, individuals can learn about their ancestry and genealogy and things like that. That's not what we're talking about. So what we're really talking about is medical grade genetic testing. I think that is one of the biggest gaps in knowledge for the public, is to understand the differences between those types of genetic testing.
So you have lots of other data from Magenta. What are you going to look at next in terms of whatever data you have at hand and might yield some interesting and maybe important findings?
We did look at some knowledge questions to see if perhaps knowledge is different between the arms and individuals who had that direct person-to-person genetic counseling either beforehand or after. So I think that'll be important to look at. We did look at completion rate and didn't see that there was a difference between completion rate between the arms. So you might imagine that if someone talk to you about the testing beforehand. You could see things going either way, either that someone may say, you know, that's not for me, or, oh my goodness, wow, this is such important information. I really am committed to it. So I think those are some things that we're going to dig a little bit more deeply into. I think the areas that we feel like we may have fallen short is that we were really hoping that this method would reach individuals in rural communities who don't have access to some underserved minority populations. And it didn't seem like we were able to reach those individuals as much as we would have liked. And so I think as a follow-up, it'll be important to really figure out how to reach those other populations that it's always been challenging to engage.
Right, right. And any thought about redesigning the video or the you know, the nuggets of information that you're delivering that apparently maybe we don't need an in-person phone call, a real-time phone call to deliver. Are you tinkering with that?
That's a great idea. I don't think we've gotten we have gotten to that point yet, but I think that's something that can always iteratively be improved.
Right. I would think it'd be particularly interesting now that maybe the phone call, you know, is least, you know, there's some question about the efficacy of it. Well, we began this conversation talking about making genetic tests accessible. So, do you think that these results and the, you know, sort of agnostic result about the need for a conversation with a genetic counselor are sort of heartening in terms of accomplishing what you seem to be interested in, which is having more women, and we're talking women in this case, get genetic tests for these life-threatening cancers that maybe could be treated earlier and with, you know, with better results.
You know, I would say that I think the study had to be done because in some ways the commercial testing was starting to outpace the academics' understanding of whether this was safe, effective, you know, useful. And so because it is available commercially, I think that the study is a big step in saying, you know, this is available. And as a physician, I feel comfortable with you as my patient using it. And I think that we've had a lot of individuals reach out to us and say, gosh, I'd love to look at this in my population of patients that have colon cancer as part of their family history or pancreatic cancer as their family history. So we focused on individuals who don't have cancer. You could even focus on individuals who do have cancer, who may not have access to genetic counseling and testing, and look at it in those individuals as well. So I think it has broad applications, both to the broader cancer patient community as well as the broader general population.
And it might make some oncologists more comfortable ordering these tests.
Absolutely.
I should have done this at the very beginning, but it's a particular test that was used here. What's the name of the test and what's the name of the company?
So we use the color genomics test.
Okay. Well, this has been fascinating, and I learned a lot, and we didn't have to go to Chicago to do it. So I think this is a sign of how everybody's adapting. So I appreciate the time this afternoon and look forward to seeing more results out of a very important trial, the Magenta trial. Thank you.
Thank you. Appreciate it.